Okay, so seizure disorders they may have. GERD. Remember that they have a lot of tightness everywhere and they're not moving the way they should. They may not be sitting up correctly, and so this promotes the onset of gastroesophageal reflux. If they have failure to thrive, many of these kids are going to end up needing a G-tube. And I'm talking the kids who have some degree of mental retardation and cerebral palsy, not the mild cases of CP. Those kids can usually eat just fine. As they go through adolescence, the kids with CP have a high incidence of scoliosis, primarily because they're not weight-bearing. They've never stand up straight to make their spine nice and straight. And others need the orthopedic devices put on them in the form of splints so that we are minimizing the onset of contractures. There can be some respiratory deficiencies, and when you look at this list of what they can have, seizures can lead to respiratory problems, GERD can lead to respiratory problems, and scoliosis can lead to respiratory problems. Scoliosis is in next week's content when we discuss musculoskeletal, but that's that S curve of the spine. When we take care of these kids, they're not coming into the hospital because they have CP. They're coming into the hospital because they have a complication of CP, and the most common reason is a respiratory illness such as pneumonia. And so you're going to be giving them all of the medications that the parents and family have been administering them when they're at home. So if they have a seizure disorder, you're going to be giving them a variety of anticonvulsants. If they have reflux, we're going to be giving them possibly a PPI or an H2 blocker, but we're also going to be giving them erythromycin at the GERD dose to promote motility. Baclofen can come as an oral or as an intraspinal pump, and so they have the baclofen pump, and this reduces spasticity and it allows them to function. You can anticipate that your child will have a G-tube, and many have a G and a J. So the G is for meds and the J is for feedings, and it will depend on how much reflux they have, how they're going to be fed. Occupational therapy will get involved to assist the younger kids in learning how to suck, swallow, and breathe, do that coordination so that they can feed at home. And then as they get older, then they're providing utensils so that the child can feed themselves. When they have braces or casts, because some of them need casts to straighten out their extremities, we'll be doing wound care. Make sure you do good skin assessment when they're using braces and casts so that they don't have skin breakdown. For the scoliosis, we want to promote as good of posture as we can possibly do and support their back with pillows and get them up in a chair as much as possible. Protect these kids from injury. Because these kids have a weak cough and they are at risk for aspiration, we need to control their secretion, so you're going to be suctioning them. If they're admitted for a respiratory illness, we're going to do what we usually do for those respiratory illnesses, providing oxygen support, giving antibiotics, possibly antivirals, and giving breathing treatments. Elevate the head of the bed, turn them side to side, and make sure your emergency equipment is at the bedside. Some of these kids who have repeated aspiration end up having a trach. The variety of therapists that are involved will be occupational therapy, physical therapy, and speech therapy. In our subacute facility, we also have a restorative nursing assistant who goes around and does range of motion. Physical therapy does that in the hospital, but our RNA does that in a subacute facility. So they will provide us with a variety of adapted devices that they need and a special wheelchair for each child. Physical therapy will work with the child to get them up and walking as much as possible and promoting the self-care behaviors like dressing, brushing their teeth, combing their hair, and feeding themselves. And speech therapy will be involved so that they can communicate. Make sure you have child life involved to help support this child as they're going through this training. Here's an example of a child with cerebral palsy who's using a wheel type of a walker to help them with walking. And you can see how this kid is walking up on his toes. And look at this little one. And this kid is so happy to be outside. And this kid will probably do fine as he grows up versus the children in this picture. So these are the more profound CP with a degree of mental retardation. So there's not a whole lot that they can do for themselves, but they still respond. Look at the smile on that one boy's face. So psychologically, depending on the spectrum that they have and if they have MR or not, when they don't, especially, we want to focus on their self-concept and watch for them to have depression, especially as they're going through adolescence. Social services and case management is involved to coordinate care because they might be seeing a neurologist, they're seeing all of the OT, PT, they're seeing pediatrician, and they might be seeing surgeons to be able to release some of these tight cords. They're going to need community resources, financial assistance. In school, when they're in the hospital, the school can come to the kid. And these children can go to a regular school, and we have special ed within that school. When we're talking to the patient as well as the family, we always reinforce the key points, the take-home points that we want, especially when we're implementing something new. Recognize that the family is the expert in this child's care. And also recognize that when the family is wondering why we're doing all of this stuff for their kid, it's because we want to maximize their potential. Do provide honest information. Remember that when we're working with a child who's hospitalized and they have CP, we must use an interdisciplinary approach. Coordinate our inpatient with our outpatient care. That is so very important. So when this family takes the child home, they have the same supportive care that they've had while they've been an inpatient. Setting up the room for the family, find out what the routines are, what equipment they use, and if we have it, bring it in there so they can replicate as close as possible to what they're used to at home. Use caution when feeding the child, especially if they have a known seizure disorder. We don't want to use plastic utensils where in their spasticity and their jerky movements, they can break and cause harm. Use their own chair that they bring to the hospital for when they're going to be sitting up because it's going to have all the straps to help support them. If you have to feed them, you want to put the food into the center of the tongue and press down so they feel it and they can go ahead and propel it back into the throat. And then try not to hit their lips too much because then the tongue starts thrusting out and nothing's going in. You have more on the outside of their face than you have going in. Pain management can be a challenge, especially when mental retardation is involved. So find out what are the nonverbal cues from their caregivers. And do remember that narcotics are not going to do anything for muscle spasms. It doesn't even help with the pain that goes along with muscle spasms. Just because a child has cerebral palsy, don't treat them like a baby. Talk to them in a manner that is developmentally appropriate. Get them out of the bed and into the playroom as often as possible. As long as they're not on isolation, they do not need to be in their room. So make sure that you have child life involved and develop your nursing care plan with their input. And you should all know seizure precautions very well by now. Patting the rails, making sure your emergency equipment is close at hand, and making sure that you administer their anticonvulsants when they're supposed to be done. And this ends the lecture on cerebral palsy.